Yeah, it's a very extensive presentation and a lot of work has been put into it. So
recording in progress.
I hope you can for the amount of slides that we have. We've gotten assistance from UKZN Psychiatry, Dr. Lindokuhle Taylor, who had actually published something on mood disorders in pregnancy and the postpartum. So I now hand you over to Dr. Nxumalo.
Good morning, everyone. I'm Dr. Nxumalo. I'll be presenting on perinatal mood disorder. The talk has been well supervised by Dr. Gama Prasad. So the outline of the presentation will be looking at introduction, epidemiology, risk factors, pathophysiology, sleep physiology, risk to mother and child of an untreated perinatal mood disorder, specific perinatal mood disorders, and then we'll look at the safety of the drugs in pregnancy, screening, lactation, and then touch a bit on the acute agitated patient. So when it comes to perinatal mood disorders, they are the most common psychiatric disorders. They may range from common psychiatric disorders such as depressive disorder to severe psychiatric disorders such as bipolar disorder. They can precede pregnancy or can develop during the perinatal period. They can affect pregnancy or the 12 months after delivery, and during pregnancy or the postpartum period, 1 in 5 women will develop an incidental mental condition. But despite their prevalence, they are often not treated or are undertreated. This is because they are often under-recognized or overlooked. And now this is associated with negative consequences for the pregnant as well as the postpartum woman. Such negative consequences include disrupted health behaviors, relationships, parenting, as well as physiology. Now, these complications interact in complex ways to create a risk for fetus or offspring, partner, as well as the family. They are, however, treatable once identified. Yet, 50% of all persons with perinatal mood and anxiety disorder are never identified. And according to the Postpartum Progress, approximately 950,000 American women self-report postpartum depressive symptoms. Each year, more women will be affected by postpartum depression than diabetes or breast cancer. So during the prenatal care, women are actually screened for diabetes, but pregnant and postpartum women are rarely routinely screened for depression. When you look at the epidemiology, psychiatric disorders can affect about 20 to 40% of the general population. Depressive and anxiety disorders have a lifetime prevalence of about 4 to 10% in the general population. And in South Africa, the prevalence of perinatal depression, stress, or anxiety ranges from 16% to 50%, with 10% of women at a higher risk of suicide during the perinatal period. When you look at the epidemiological studies, they've actually suggested that psychiatric disorders are more prevalent in females compared to males, with women having a rate of 1.5 to 2.5 times than that of men. 20 to 30% of pregnant women present with at least one psychiatric disorder. Now, the strength of association of pregnancy with psychiatric disorder at the moment is currently unclear. So when we look at the risk factors for perinatal mood disorders, they are multifactorial, and there is also sort of like an interplay between the risk factors in terms of influencing each other and contributing to perinatal mood disorders. Now, this table is based really on a systematic review. But there are some of the risk factors which are sort of clinically more relevant as opposed to others. So they range from psychological, psychiatric factors, such as personal history of mental illness, psychiatric treatment, current substance use during pregnancy, all the way to family history of psychiatric illness. And when it comes to social support and marital relationship factors, they range from lack of partner or social support to social conflict, to then history of abuse or domestic violence, all the way to the single mother or the partner not living within the household. And when it comes to your social, demographic, and economic factors, both the extremes of age and particularly high risk of perinatal mood disorders, all the way to unemployment, as well as the partner that is actually unemployed. And when you look at specifically to obstetric and pregnancy-related factors, unplanned pregnancy, multiparity, nulliparity, history of pregnancy complications, all the way to those pregnancies that are conceived through infertility, they seem to be a particularly increased risk of perinatal mood disorders. So when it comes to the pathophysiology, there is this known interplay between hormones and neurotransmitter systems, such as monoamine oxidases. Some of the neurotransmitters involved are monoamine oxidase B, serotonin, as well as norepinephrine, which have been specifically studied in the perinatal population. Through the use of PET scans, the researchers have actually found that monoamine oxidase A levels in the early postpartum period correlate with a decrease in estrogen level. Now, this suggests a model in which an acute monoamine lowering contributes to change indicative of postpartum blues as well as postpartum major depressive disorder. There is also a partial support among other researchers that have actually assessed peripheral markers of neurotransmitter activity. An example being platelet serotonin, which is lower in the postpartum women with major depressive disorder than in those without major depressive disorder. Also, serotonin transporter activity is greater in postpartum women with as compared with those without depressive symptoms, while serotonin levels in platelets actually correlate with the severity of postpartum blues at 5 days postpartum. So this implies that lower synaptic serotonin may lead to depressive symptoms in a postpartum woman. And also, in one of the studies, they actually they looked at the metabolite of norepinephrine. They found that it was elevated after delivery in women with compared with those without depressive symptoms. There's also a role played by the hypothalamic pituitary adrenal axis, where essentially it's mentioned that major depressive disorder has long been associated with hypothalamic pituitary adrenal axis dysfunction. Now, the events of pregnancy as well as maturation may disturb this system. And when it comes to non-pregnant individuals, they actually have this elegant feedback mechanism whereby corticotropin releasing hormone as well as adrenocorticotropin autoreceptors decrease hormone production in the hypothalamus, the anterior pituitary, as well as the adrenal cortex. Whereas in pregnancy, the placenta actually independently produces a number of hormones, which includes your corticotropin releasing hormone, ACTH, as well as cortisol, which are now then regulated in a feed-forward manner, which leads to a downregulation of autoreceptors in the hypothalamus as well as in the anterior pituitary. Now, this process of receptor downregulation and the transition to a non-pregnant hormonal state has been hypothesized by some to constitute a period of vulnerability for mood disorders. When it comes to the suppression of ACTH by bovine corticotropin releasing hormone, it is actually more profound among depressed postpartum women than those without depressive symptoms. And further evidence has actually suggested that cortisol response is uncoupled from ACTH secretion in depressed as compared to with those that are non-depressed individuals. There is also a role played by the immune system. So essentially, delivery of a newborn stimulates a pro-inflammatory state, presumably attributable to pain, physical exertion, and tissue injury involved in delivery. These pro-inflammatory cytokines, they are linked to hypothalamic pituitary adrenal axis activity, and they've been associated with mood disorders in non-pregnant individuals. Interleukin-1 beta, which is a pro-inflammatory cytokine, is released from white blood cells, and it's actually found to be elevated in the first month postpartum. And in a cross-sectional study that looked at serum interferon gamma, interleukin-10, as well as cortisol levels, which were measured in postpartum women, they were actually found to be lower in those who had depressive symptoms, which was suggestive of a hypoactive hypothalamic pituitary adrenal, as well as a mixed pro-inflammatory response. When it comes to the thyroid function, a relationship exists between thyroid function as well as mood disorders, which is well established. And thyroid axis is affected by pregnancy via the chorionic gonadotropin on the thyroid gland itself. It constitutes an area of biological vulnerability for depression in pregnancy as well as after delivery. So both hypothyroidism as well as hyperthyroidism are risk factors for mood disorders. Elevated thyroid autoantibodies are also a risk factor for depressive symptoms in pregnancy as well as after delivery. And what about melatonin? Well, Perry et al. Has actually found that pregnant women with major depressive disorder had lower melatonin levels, and that postpartum women with major depressive disorder had higher melatonin levels as compared with their non-depressed counterpart. And there's also a role played by familial aggregation as well as genetic studies. In a report made from the genetics of recurrent early onset major depressive disorder study, they revealed that having a sibling with major depressive disorder during or after the delivery, during pregnancy or after the delivery, it increased the odds of a similar episode in the other sibling by 2.28. And also having a sibling with postpartum major depressive disorder, it increased the odds of having a postpartum major depressive disorder by 4.96. And when it comes to the role played by genetic studies, polymorphism in the serotonin transporter gene, it actually leads to either low or high expression of serotonin transporter. This high expression of transporter gene is linked with depressive symptoms, particularly when serotonin precursor, which is tryptophan, is relatively depleted. Now, the postpartum period is actually the time when tryptophan is relatively depleted, and the high expression of polymorphism is associated with elevated scores of Edinburgh postnatal depression scale at 8 weeks postpartum, but not necessarily at 32 weeks postpartum. There is also a role played by sleep physiology, whereby changes in sleep physiology as well as sleep deprivation, they have been proposed as having roles in perinatal psychiatric disorders. This is due to a change in physiological state. Now, this results from alterations in the balance of major neurotransmitter systems in the brain. And some of these transmitters are actually responsible for multiple functions in the brain, including the functions relevant to psychiatric disorders. So there's this significant interaction that could occur between sleep as well as and psychiatric disorders. So that some of the neurotransmitters that are involved ranges from serotonin, norepinephrine, all the way to your acetylcholine, which are all major role players in the coordination of sleep and wake behaviors. But what about pregnancy-related sleep changes? There has been studies that have identified a number of features that are characteristic of poor quality of sleep in pregnancy and postpartum. In fact, in a study of 33 pregnant women who underwent polysomnography at home, total sleep time increased in the first trimester, but then decreased again by the third trimester. There was a reduction in slow wave sleep and as well as increased awakening throughout the night, which then led to reduction in sleep efficiency. Sleep difficulties were actually found to be worse in the first month postpartum. As well, also symptoms of insomnia associated with a significant risk for new onset depression and anxiety disorder, and sleep disturbances are among the most common symptoms of psychiatric disorders. So therefore, manipulations of sleep as well as circadian rhythms are useful treatments for mood disorders. We'll just now look at the risk associated with an untreated mood disorders. On your left, the maternal mood disorders ranging from your depression disorders to bipolar disorders, as well as anxiety disorders. And then on your right is the pregnancy risk, as well as the outcomes associated with each particular disorder. So if you look at depressive disorders, the pregnancy outcome ranges from inadequate maternal weight gain to fetal distress, as well as an increased NICU admission, whereas in bipolar disorder, it ranges from low bed weight, as well as high postpartum risk for first onset and recurrent bipolar disorders and hospitalization, to substance use, poor prenatal care, as well as maternal suicide. Whereas with anxiety disorders, increased risk of preterm birth, spontaneous abortions, all the way to excessive infant crying. And then now we'll just touch on each mood disorders. We'll start with perinatal depression. It is defined as a major depressive disorder with an onset specified. It includes an onset of depressive symptoms in pregnancy or up to 4 weeks postpartum. And most clinical experts actually recommend that the application of this terminology should be up until 12 months postpartum. It is common, with the rates ranging between 12% and 22%. That is now 2 times that of the general population. Symptoms of depression can differ from significantly from person to person. It ranges from irritability all the way to suicidal ideation. And when it comes to the clinical diagnosis, you have to meet some, but not necessarily all of the specified criteria. Now, when we look at the signs and symptoms of depression during pregnancy, they are actually indistinguishable from the major depressive disorder during other times in a woman's life. However, certain symptoms are more significant in pregnancy as they impact the pregnancy itself. A classic example is poor appetite. It can be a problem for anyone with depression. It's concerning when a pregnant woman is not gaining weight or losing weight because of its impact on the fetus. The same applies for substance use, sleep disorders, as well as suicidality. Depression during pregnancy has been associated with poor maternal health behaviors as well as a risk of postpartum depression. Now, in this study, it's a cohort study that was done in PAL. Basically looked at 831 women. Essentially, what it wanted to assess was the symptoms during pregnancy as well as in the postpartum period in terms of how perinatal depression behaved. So what they found is in about 82.9% of women, they actually have mild symptoms during pregnancy and with a slight slight decrease in the postpartum period, whereas there was a 3.1% of women who actually had severe symptoms during pregnancy as well as in the postpartum period. And when they looked at this cohort of patients that had severe symptoms, they actually found that it was associated with stressful life events, sexual intimate partner violence, as well as tobacco use. And how we diagnose it, we use the Diagnostic and Statistical Manual of Mental Disorders, so in short, DSM-5. The major depressive disorder is characterized by one or more major depressive episodes. It has to be persistent and abnormally depressed mood. It must last at least 2 weeks, and there has to be significant general loss of interest and loss of the ability to experience pleasure. There are cognitive symptoms as well as physical functions, which include depressed mood, loss of interest, all the way to insomnia, as well as hypersomnia. Other symptoms include your psychomotor agitation or retardation, fatigue or loss, lack of concentration, all the way to thoughts of suicidal death or suicidal ideations. So when we look at the complications of depressions in pregnancy, untreated depression complications include suicidal ideation or attempt, substance misuse, preterm birth, low birth weight, as well as fetal growth restriction. And when we zoom in those patients who are particularly at risk to committing suicide, suicide during pregnancy is a substantial cause of maternal mortality globally. And the risk factors include the history of mental illness, those who actually stop medication during pregnancy, as well as intimate partner violence. How do we treat it? Then we use the American College of Obstetrics and Gynaecology, which then recommends to us that psychotherapy be considered as a first-line treatment for mild to moderate perinatal depression, with selective serotonin reuptake inhibitors being used as the first-line pharmacotherapy, and serotonin norepinephrine reuptake inhibitors as a reasonable alternative. Pharmacotherapy has to be individualized based on prior responses to therapy. And if no pharmacotherapy history, then you can use sertraline or citalopram, which are reasonable first-line medication. You can consider the use of brexanolone administration in postpartum period for moderate to severe perinatal depression with onset in the 3rd trimester or within 4 weeks of postpartum. We'll come back to brexanolone later on in the presentation. What about bipolar mood disorders in pregnancy? Well, the onset typically occurs in late adolescence or early adulthood. The lifetime prevalence is about 1% in the general population. Individuals with bipolar disorder often have the symptoms or diagnosis of the majority of their reproductive years. Recognition is important. This is because childbirth is one of the most potent precipitant of hypomania or mania. So mania poses a clear risk to a pregnant woman and an unborn child due to its impulsivity as well as impaired judgment. And the risk of psychiatric hospitalization in the postpartum period is significantly greater than at any other point in a woman's life. It includes both bipolar 1 disorder as well as bipolar 2 disorder, with bipolar 1 disorder being defined by at least one episode of mania that may include psychotic features, while bipolar 2 disorder is characterized by hypomania, which is a less severe form of mania without psychotic symptoms. Episodes of mania occurs in addition to episodes of depression, and there has been these sex differences which have been documented with females more often presenting with depressive polarity compared to manic or hypomanic polarity, and bipolar 2 disorder compared to bipolar 1 disorder. Women with bipolar are often diagnosed later or misdiagnosed with a depressive disorder. In fact, in a quarter of positive perinatal depression screen, you will actually find the bipolar disorder. You find a bipolar disorder if you further evaluate that patient. There's also, because of the prominent depressive symptomatology in perinatal women, bipolar is often mistaken for unipolar depression. Before prescribing antidepressant monotherapy for presumed unipolar depression, a bipolar disorder screen is needed to avoid precipitating mania or psychosis. This has been associated with self-harm as well as infanticide. So the risk of bipolar disorder, particularly postpartum, is 35%, with marked differences between those not treated with pharmacotherapy compared to those in whom pharmacotherapy is continued. And where there is discontinuation of pharmacotherapy for bipolar disorder in pregnancy or the postpartum period, that is associated with a 3 times higher relapse compared to non-perinatal women. How do we then treat it? We use mood stabilizers. They are the gold treatment for acute episodes. They range from lithium carbonate to anti-epileptics as well as antipsychotics, with antiepileptics including carbamazepine, lamotrigine, and then with antipsychotics including olanzapine, quetiapine, as well as aripiprazole. The choice of mood stabilizer should take into account the presenting episode. Is it manic or depressive? And the stage of pregnancy in terms of trimester. First trimester, we encourage the use of olanzapine as it is the preferred choice for treating acute manic episode due to its low to moderate risk of teratogenicity, whereas lamotrigine is an effective mood stabilizer for bipolar 2 disorder and in preventing relapses. There is a role of the electroconvulsive therapy, which should be considered in severe depressive and in manic episodes where treatment response to pharmacological intervention is unsatisfactory. Also, the American College of Obstetrics and Gynecology further recommends to us, one, not to discontinue mood stabilizers except for valproate during pregnancy. This is due to a high risk of recurrence or exacerbation of mood symptoms. They advised us against using valproate as the first-line treatment for bipolar disorder. And pregnant individuals using antipsychotic medication should undergo screening for gestational diabetes mellitus, which is consistent with our standard prenatal care. This is because olanzapine has got a particularly increase the risk of metabolic syndrome. And those who are using lithium in the first trimester, they should get a detailed ultrasound examination in the second trimester. And also it's necessary to monitor lithium levels during pregnancy as well as in the postpartum period. We'll touch a bit on the anxiety disorders in pregnancy. They often comorbid with perinatal depression. And during pregnancy, it has been associated with preterm birth and low birth weight. And perinatal anxiety disorders have been associated with behavioral challenges in offspring. Studies actually show that infant of mothers with perinatal mood and anxiety disorders have less mature regulatory behaviors, heightened negative emotionality, as well as increased cortisol reactivity, highlighting a possibly altered development trajectory. Anxiety disorders have been associated with fear, cesarean section request, increased risk of suicide and premature delivery. And anxiety emergencies may present as panic attacks, which are characterized by severe distress and discomfort for a pregnant woman. Now, panic attacks may sometimes be confused for cardiovascular disease, respiratory illnesses, as well as epilepsy, as a result leading to unnecessary investigations and wrong treatment. So a thorough history and performing the necessary examination as well as investigation during a panic attack cannot be overstated. When it comes to the DSM-5, the types of anxiety disorders include your generalized anxiety disorder, your social phobia, your selective mutism, as well as your phobia-related disorders. And each of these conditions hold a distinct diagnostic criteria, often comorbid and share the common symptoms of fear and anticipatory anxiety, as well as behaviors often manifesting as avoidance. Now, the prevalence for a diagnosis of any anxiety disorder is about 10 to 15% in pregnancy. How do you treat it? Well, we use the first-line treatment is psychotherapy as well as antidepressant, with cognitive behavioral therapy being the first-line choice for treating mild to moderate anxiety disorder. The American College of Obstetrics and Gynecology recommends selective serotonin reuptake inhibitors to be used as a first-line psychopharmacotherapy with, again, sertraline and the citalopram. But in the low to middle-income countries, we can use citalopram as an alternative option, but it may take up to 4 weeks for the effect of citalopram to become apparent. Serotonin norepinephrine reuptake inhibitors are to be reserved as a reasonable alternative. We may require higher doses initially, and as well as in severe cases. So short-term intermittent use of benzodiazepines such as clonazepam can be considered to alleviate symptoms. Now, this table, what it shows is basically the first-line treatment options you have for mild, moderate or severe depression, anxiety disorders, as well as PTSD. It further then tells you exactly what dose to prescribe, when to reassess the patient, and how much you should increase the dose with if you are not happy with the resolution of the symptoms. And then, so we'll take an example, for instance, citalopram, you can start it at 10 milligrams in the morning, you reassess the patient at 4 days after, and then if you're still not happy in terms of the symptoms, then you can increase it to 20 milligrams, and then you reassess the patient monthly, and you will then increase it by 10 milligrams until you are happy in terms of there's now resolution of the symptoms. We're aiming for a therapeutic range of about 20 to 40 milligrams. And this table as well is it's exactly the same as the other one, except that this one is showing second-line treatment options that you have for mild, moderate, or severe depression, anxiety disorder, and PTSD. With this treatment algorithm, essentially what it shows is to help you differentiate that when you're seeing a patient in front of you, you ask this certain questions, and if you follow a certain way. For instance, you say you ask the patient and say, does the patient have current mania or history of bipolar? And she says no. Then does the patient have the psychotic symptoms? If she says no, does the patient have major or minor depressive disorder? And if you're saying yes, is it severe? And if it's yes, then you can consider treating that patient with antidepressant, and then you can actually, that patient can actually benefit from psychotherapy. And if you go the other way around, then you'll end up with bipolar mood disorder. And if you go down the center, you will actually end up with a sort of a mood disorder severe enough to have psychotic features. And then you can actually start the patient on atypical psychotics and combination the patient with a psychiatrist. However, if irrespective of where you end up, but if the patient answers yes in the question that says, does the patient have suicidal or homicidal ideation, then that patient warrants to be referred to a psychiatrist or to an emergency department immediately. We're going to look at the safety of drugs in pregnancy. We'll start with your selective serotonin reuptake inhibitors as well as your SNRIs. There has been animal studies which did not suggest any teratogenic effect for sertraline as well as citalopram. It was only on toxic doses for citalopram, and these are at doses which are greater than maximum recommended human dose, where they found that there was increased risk of skeletal abnormalities and decreased fetal growth or survival, associated with increased risk of cardiovascular malformation. Whereas with paroxetine, it is linked with cardiac malformations such as ventricular septal and valve defects. So with this one, they actually advise against using it. If the patient is on it, you can either discontinue it or switch it to another antidepressant. So the general warning by the Food and Drug Administration on these drugs is that they've done a study of women with a history of major depression who were euthymic at the beginning of pregnancy, and it actually showed that those patients who discontinued antidepressant medication during pregnancy, they were more likely to experience a relapse than women who continued medication. And the neonates that were actually exposed late in the third trimester, they actually developed complications requiring prolonged hospitalization, respiratory support, and tube feeding. And some of the clinical findings that they actually found in these neonates were issues like respiratory distress, temperature instability, all the way to irritability as well as constant crying. And in some cases, the clinical outcome is actually consistent with serotonin syndrome. And when it comes to your antidepressant, there's been few teratogenic effects which are reported, except at doses of amitriptyline, which far exceeds the maximum recommended human dose. The results of animal research on decipramine and triptyline as well as imipramine, they are actually described as being inconclusive. And at doses greater than maximum recommended human dose, there was increased pulp mortality and low bed weight, which were reported for amoxapine as well as doxepine. Whereas with trimipramine exposure at 20 times maximum recommended human dose, it actually caused an increased risk of major abnormalities. There are no adequate and well-controlled studies in pregnant women. And adverse events in humans includes your central nervous system effects, limb deformities, developmental delays, which have been reported for amitriptyline. And neonatal withdrawal as well as anticholinergic symptoms have been observed as well. So the kinetics of these drugs change during pregnancy. So serum levels should be monitored and the dose should be adjusted if needed. What about atypical antidepressant? Animal studies actually show no clear evidence of teratogenic effect, but there is high pulp mortality rate and lower bed weight at doses which are greater than maximum recommended human dose. There are no adequate and well-controlled studies in pregnant women. And what about the benzodiazepine? Animal studies actually suggest that there is a risk for the teratogenic effect. There has been malformations such as cleft palate which have been observed, and with temazepam, it has caused anencephaly as well as fusion or asymmetry of ribs, and is contraindicated in women who are or may become pregnant. And patients should be instructed to discontinue drug prior to becoming pregnant. And the General Food and Drug Administration warning when it comes to your benzos is that first trimester exposure is linked to an increased risk of congenital malformation, which has been suggested in several studies. Whereas with non-teratogenic risk will include reports of neonatal flaccidity, respiratory and feeding difficulties, hypothermia, and neonatal withdrawal symptoms during the postnatal period. So the use of these drugs is honestly really a matter of urgency. So first trimester exposure should almost always be avoided. When it comes to your mood stabilizers, with lamotrigine, there was no increase in teratogenicity, neither there was a delay in neurodevelopment. With lithium, they said the absolute risk of cardiac malformation is rare, but watch out for newborn floppy baby syndrome. With carbamazepine, they said there was a potentially increased risk of cleft lip or palate, with a risk of reduced head circumference and lower bed weight and shorter length as well being there. With valproate, they said there was an increased risk of multiple malformation, and also there was neurodevelopmental lower IQ. When it comes to atypical antipsychotics, there were no major findings, but the data was limited. We'll just now have a look at the postpartum period. Mood disorders following childbirth are typically classified into 3 categories, or you can call them syndromes: postpartum blues, postpartum depression, as well as postpartum psychosis. When it comes to postpartum blues, which is what I think we commonly see, is they are mild and they are usually transient disruptions affecting women within the first 10 days after delivery. They're not typically thought to reflect psychopathology, and symptoms are not severe enough to actually impair functioning. But when it comes to postpartum psychosis, women with a history of bipolar disorders are at a particularly high risk of developing postpartum psychosis. Postpartum psychosis mothers actually have a 50 to 80% chance of another psychiatric episode, and it's usually within the bipolar spectrum. It is considered a medical emergency that requires immediate treatment because of its rapid onset as well as progression. It is rare, affecting about 0.1% to 0.2% in the first 4 postnatal weeks. It often occurs in the context of bipolar disorder type 1, which is where basically there is the highest risk. And DSM-5 specifies that the diagnosis must occur within the first 4 weeks post-birth. Symptoms fluctuate over time, making prompt recognition of the utmost important. Most women admitted with postpartum psychosis do not have a known psychiatric history. So a pre-birth planning meeting, including your partner, family, friends, other support persons, mental health professionals, obstetric care teams should be used to coordinate postpartum psychosis prevention planning. Now, this will include talking about psychopharmacology, how we observe the patient and the support and the adequate the support that's available to the patient, and then to also prioritize adequate sleep strategies for the patient. How do we treat it? Antipsychotics plus minus benzodiazepines such as lorazepam. Second generation drugs such as quetiapine are preferred because of reduced extrapyramidal side effects, as well as a reduced risk of congenital malformation. With the risperidone, though, there is an increased risk of congenital malformation. Hebert et al. Actually looked at the association of antipsychotic use in alien pregnancy and with the risk of congenital malformations. This was a cohort of over 1 million women, and they concluded by saying that antipsychotics aid in pregnancy does not meaningfully increase the risk of congenital malformations or cardiac malformations, with the possible exception of risperidone. Also, clozapine and olanzapine are associated with a higher risk of metabolic syndrome. To manage psychosis, it requires a multidisciplinary team approach, which will include your psychiatrist, your obstetrician, your psychologist, your social worker, and for long-term treatment, you may include pharmacotherapy, and sometimes they may actually require electroconvulsive therapy. When it comes to breastfeeding in the context of postpartum psychosis, foregoing breastfeeding overnight as part of the sleep preservation and support can also be helpful in early phase of treatment and stabilization. And if treated quickly and appropriate, full remission can be achieved in 2 months postpartum. What about perinatal depression? Well, it's a serious mental health condition occurring after childbirth, and it's characterized by emotional disturbance and behavioral changes. It also often features elements of postpartum anxiety. The criteria for a major depressive episode and symptoms beginning in pregnancy or within 4 weeks of delivery as per the DSM-5. Women who experience symptoms of depression postpartum may actually feel guilty or embarrassed by them, and they may also hope that their symptoms will eventually subside without treatment. And how we treat it? First-line treatment for perinatal depression is psychotherapy and antidepressant medication. The American College of Obstetrics and Gynae recommends that we use serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, as well as tricyclic antidepressant. Selective serotonin reuptake inhibitors, again, are a first choice of medication, with sertraline or citalopram being a good first choice of medical therapy. We can consider switching to serotonin norepinephrine reuptake inhibitors or mirtazapine if SSRIs are ineffective. Psychotherapy is the first-line treatment option for patients with mild to moderate peripartum depression, and a combination of therapy and antidepressant is recommended for moderate to severe depression. Now we'll have a look at the role of the neurosteroid therapy in the management of postpartum depression. It's worth noting that they're quite expensive, and brexanolone is still not yet available in the country. Zuranolone is available in the country, but it's quite expensive. I think it's about $14,000 US dollars for a 2-week course. So let's start with brexanolone. It is an intravenous neurosteroid that positively act at GABA A receptors. It is an analog of allopregnanolone, a metabolite of progesterone. The first medication was approved by the Food and Drug Administration in March 2019 for the treatment of moderate to severe postpartum depression. Brexanolone is administered intravenously as a continuous 60-hour infusion lasting about 2.5 days. And multiple clinical trials have actually demonstrated that it is well tolerated with women with moderate to severe postpartum depression, but there is no data to support its safety with breastfeeding or efficacy beyond the 30-day use. And when it comes to your zuranolone, it's a neuroactive, again, a steroid like brexanolone. It is also a GABA A receptor modulator approved by the Food and Drug Administration on the 4th of August last year for postpartum depression management. It is a 50 milligrams oral dose that is taken every night with a fat-containing meal for 14 days. It may be used alone or with other oral antidepressant. It is well tolerated but has minimal side effects. It has been suggested that it can produce harmful effects actually on the fetus during pregnancy and lactation, and hence maybe to use it postpartum. There is also a role played by TMS, and it's also available in the country. It's short, basically transcranial magnetic stimulation. This is a non-invasive procedure that uses magnetic waves to stimulate and activate cells in targeted areas of the brain. Now, these cells are actually underactive in people with major depression. It's usually done once a day for 4 to 6 weeks to be effective. And this therapy may be used in patients that are not responding to antidepressant and psychotherapy. It's usually well tolerated, but side effects can include headaches, lightheadedness, scalp discomfort, as well as facial twitching. And although early results are promising, future studies still need to be done to address the benefits on postpartum depression. And with electroconvulsive therapy, patients with severe postpartum depression may not respond to psychotherapy and pharmacotherapy. So for patients with refractory to 4 consecutive medication trials, electroconvulsive therapy may be recommended. ECT is beneficial in patients with psychotic depression, and especially with the intent of committing suicide, those who have an intent of committing suicide, infanticide, or those that refuse to eat and leading to malnutrition as well as dehydration. And observational studies have actually suggested that ECT is a safer option for lactating patients, as there are fewer adverse events for the mother and the infant. We'll now just look at the bit on the screening of depression. We're now getting closer to finishing. The screening for depression is consistent with the guidelines of the American College of Obstetrics and Gynae, the NICE guidelines, as well as the American Academy of Pediatrics. The rationale, again, for screening is that postnatal depression is serious, it's prevalent, it's under-recognized, and it's treatable. There has been standardized various screening tools which are available, which the mostly widely used one is the 10-item Edinburgh postnatal depression scale. But before you use that tool, the NICE guidelines actually recommend that when we see a woman at first booking, as well as at early postnatal period, we should screen with just 2 questions. To screen for depression, you can just ask at least the following 2 questions, with the first question being, during the past month, have you often been bothered by feeling down, depressed, or hopelessness? Second question being, during the past month, have you often been bothered by having little interest or pleasure in doing things? And then if you want to now screen for anxiety, you can just use the 2-item generalized anxiety disorder scale, and where you ask over the last 2 weeks, how how often have you been bothered by feeling nervous, anxious, or on edge? And then over the last 2 weeks, how often have you been bothered by not being able to stop or control worrying? And if they screen positive in the brief screen for depression, then you can use your Edinburgh postnatal depression scale with an alternative of what they call the PHQ-9, which is the patient healthcare questionnaire, for a full assessment. Whereas with those that screen positive for anxiety, then you can use the 7-item generalized anxiety disorder scale for a comprehensive assessment. Now, this is a picture depicting basically the Edinburgh postnatal depression scale. Majority of the question, essentially, they try to tease out for symptoms for perinatal depression, with perhaps the exception of question number 4 and 5, which read number 4 saying I have been anxious or worried for no good reason, and number 5 says I have felt scared or panicky for no very good reasons. This one seems to be teasing out symptoms for anxiety disorders in pregnancy. Remember, we said perinatal anxiety disorders in pregnancy often come with perinatal depression. So if the patient scores less in the other questions and then they scores high in this question number 4 and 5, perhaps maybe you should use the anxiety depression. You should screen basically for anxiety. So the responses are scored between 0 to 3 with the maximum scores of 30. It provides a good to excellent performance. In fact, in a meta-analysis of 36 studies, which included about 9,000 pregnant and postpartum women who were screened, about 1,330 were found to have a major depression. This was based upon a semi-structured interview. And the optimal cutoff for maximizing sensitivity plus specificity in detecting major depression was greater than 11, and with a positive predictive value exceeding 60%. And this is just, I want to go through this one as well. It's just, this is the PHQ-9, which is the patient healthcare questionnaire, and this is the generalized anxiety disorder scale questionnaire. This is what we found in the new maternity case record. Essentially, it seems like they actually took a bit of the questions from the NICE guidelines, the 2 questions that I spoke about earlier on. The first question and the second question, they are taken from there, and then they actually then added a screening for those patients who are actually at a particular risk for suicide. And then those that score more than 2, then you have to refer for counseling or to a psychologist or social worker. And then, and then let's now look at the lactation in the context of perinatal mood disorders. Well, it should not be discouraged. Patients who have perinatal mood disorders should not be discouraged from breastfeeding. If a patient is stable in a particular medication throughout pregnancy, we should not change his postpartum, as fetal exposure supersedes exposure through lactation. In fact, in a study that was done by Jen Oysten-Belle et al., they found that antidepressant exposure is 5 to 10 times lower in the breastfed infant compared with in utero exposure. And they encourage the same drug regimen during lactation must be used, basically the drug that was used during pregnancy must be used during lactation so as to prevent withdrawal in the neonate. And if the drug is initiated during lactation, passage through breast milk should be considered along the likelihood of drug efficiency. Medications of which there are available safety data are preferred over the medications which have been recently introduced. And it has to be personal, and you have to follow that there is a personal history of basically the patient that has had a personal history of drug effectiveness. Basically, you want to use that particular drug that has been proven to be effective in that patient in order to guide the clinical decision. When it comes to the relevant relative infant dose, it should be considered, which reflects the measure of the infant's exposure to the medication through breast milk relative to the mother's dose. This dose is actually influenced by several factors, including your lipid solubility, half-life, oral bioavailability, molecular weight, drug ionization, and protein binding. And a relative infant dose that is less than 10% is considered compatible with breastfeeding. Infant exposure to medication through breast milk can generally be decreased by choosing a medication with shorter half-lives and greater protein binding. And there's little evidence to actually support the timing of drug administration or discarding breast milk, which are both impractical and can actually make breastfeeding quite difficult. What about preserving sleep? Where breastfeeding typically disrupt sleep, and this may exacerbate mental disorders. So breastfeeding should be done, but we should try to minimize chronic sleep deprivation. Mothers that can pump, a mother essentially can pump milk during the day so that the family can actually bottle feed the baby at night. And we try by all means to aim for the mother that has got perinatal mood disorder to get at least about 4 to 5 hours of sleep. And if the mother was unable to pump an adequate amount of milk during the day, the infant can be bottled for throughout the night during the time where the mother's sleep is actually prioritized. And then when it comes to the management of the acute agitated patient in pregnancy, any psychiatric illness may develop acute agitation, or it can actually develop de novo. This may escalate to aggression, potentially leading to harm to self, fetus, and others. And so early identification is essential. Now, this will require us to do comprehensive assessment and regular monitoring of the mental state of the pregnant woman with an existing psychiatric illness. Thorough assessment, which will include psychiatric evaluation, physical examination, as well as investigation, should be conducted to exclude other potential non-psychiatric causes, such as suboptimal pain control, as well as delirium. And it is recommended that you start with de-escalation and then rapid tranquilization. De-escalation, it essentially involves communicating with the agitated patient in a very calm, empathetic, and non-threatening manner, in a verbal as well as non-verbal manner, while providing emotional support. And when an agitated patient is due to paranoia, such as in the case of psychosis, de-escalation may sometimes also involve moving the patient to an environment where they feel safe. Whereas with rapid tranquilization, during pregnancy, it is a complex issue and may lead to legal issues. So it must only be considered when de-escalation has not been effective or when the agitation is very severe. So during rapid tranquilization, parenteral administration of drugs such as your benzodiazepine, antipsychotics, and antihistamine are administered to the patient. And when choosing the preferred drug, factors to consider are your drug-to-drug interaction, sedation, as well as the effect on the cardiorespiratory system. Now, this is the table just depicting the drugs that are options that are available for you if you want to do a rapid tranquilization. Short-acting benzodiazepines such as clonazepam or lorazepam can be used safely for rapid tranquilization. However, when used close to the time of delivery, it may lead to unintended neonatal benzodiazepine intoxication as well as withdrawals, especially when the exposure is prolonged. Ideally, when choosing the drug for rapid tranquilization, the clinician should also consider a drug that the patient has previously responded to and avoid the agents that the patient has had adverse outcomes on it. And when it comes to mechanical restraints, essentially treating an acute agitated patient with mechanical restraints is not advised. It should only be considered when all other de-escalation and rapid tranquilization have not been effective. And even in that case, it can raise a whole lot of ethical issues, and even if when it's used, it should be very brief. Okay, now let's conclude. So when it comes to perinatal mood disorders, they are common in pregnant and postpartum women with serious consequences for both the mom as well as fetus and the baby. And they therefore deserve the attention of an obstetrician. Screening with instruments that have been validated for use during and after pregnancy is merited at once in pregnancy and at least once during postpartum period. Non-pharmacological treatment for depression, such as cognitive behavioral therapy, as well as complementary treatment, can produce symptom relief. And pharmacological treatment should not be ruled out where evidence suggests that they are safe when prescribed and monitored safely. Perinatal mood disorders requires a high index of suspicion and a multidisciplinary team approach. This is just, I'm not going to go into detail with this one, but this is a nice read. It comes from our local psychiatric colleagues, and essentially they look at psychiatric emergencies during pregnancy as well as in the puerperal period in low as well as in middle income countries. Thank you.
Thank you, Dr. Nxumalo, for that comprehensive presentation. As you can see, perinatal mood disorders can lead to drastic consequences for both the mother and the fetus. It is very prevalent and is largely multifactorial. It is pivotal that our patients are screened for mental care issues during pregnancy. Abruptly discontinuing or not starting a patient on pharmacological therapy can be disastrous, with suicide and infanticide as the final result. So I know when we see patients in ANC, sometimes you say, oh, the patient is fine, let's just stop the citalopram. But I think we should involve the psychiatrist first, and it might be more beneficial for the mother to continue the medication than stop it. Literature states that pharmacological intervention, most of the time, the benefits of it will outweigh the risk during pregnancy and lactation. Caring for the acutely agitated mother will be most of the time our primary goal, with de-escalation and sedation the order of the day. So most of the time when we deal with these psychiatric patients, it's most of the time to de-escalate them, tranquilize them, or whatever it is, calm the situation down and then refer them adequately. No one's going to ask you to start them on the fourth line antipsychotic or something like that. That's when you institute the help of psychiatry. Caring, however, we need to have a multidisciplinary approach involving the social worker, psychologist, and psychiatrist. Just in closing, we were lucky to get assistance. I contacted the Department of Psychiatry, and the author of the article, Dr. Taylor, who helped us go along with this presentation, and his contributions we are forever grateful for. We now open the floor to any questions. Dr. Moran.
Thank you very much, and well presented at high speed. Can you just go back one slide, the previous slide? Yeah, the conclusion. So, yeah, the second bullet there. Screening with instruments that have been validated for use during and after pregnancy is merited. At once in pregnancy and at least once during the postpartum. So I wish you had spent a little bit more time on the South African screening tool. You did mention, you showed a picture of it and you briefly went over it, but that is a tool that was developed in South Africa. Yes, it took elements from the Edinburgh mental health screening and simplified it, same as NICE did, but that is the South African screening that's been validated in South Africa. And everybody should know exactly the content of that screening, because it's now a routine part of antenatal care. So if anyone is seeing an antenatal patient, they must check whether they've had this screening, and they can do the screening themselves. It's very short and easy to do. Although if you've got a patient who, is not really an English speaker, one will have to try to translate the content into the person's language. But this is a routine thing. So whenever you see an antenatal patient who's been referred for preeclampsia or whatever, one of the things you must do is check whether they've had the mental health screening, because otherwise we just skip over it. And so this might be done routinely at the first visit by the midwife, but one of the things that you have to do in antenatal care is check on this screening. One of the questions is to screen for depression. The second question, or I can't remember which way around it is, one of the questions is to screen for anxiety. And then, as you said, the third one, especially if one of the first two is positive, is to see whether there's a risk of suicide, which of course we've been seeing some cases of that, especially in the teenagers. So yeah, I just wanted to emphasize that everyone must be familiar with that screening. It has been validated in the South African setting, and it's very easy. And if you see some other kind of screening that somebody has put in, because there are some other departments like primary healthcare who are trying to put much more complex screening tool, this one has been validated and is more practical and easy. So that was one comment. The second thing I had was a question. If you have a postpartum patient, as we now and again come across, who has got a severe mood disorder, let's say major depression or bipolar disorder manifesting in the postnatal period, otherwise no obstetric problem, where should that patient be managed? Should she be managed in an obstetric unit? Or should she be managed in a psychiatric unit? Because we usually have sort of separate psychiatric hospitals and so on. And what should happen to the baby in those circumstances? Because this is a practical issue sometimes.
Okay. To answer it, I'll say one, it will depend within the hospital that you are working with, because there are those sort of in-hospital policies that they have. I think ideally, a patient, depending now on you're saying it's a severe condition. I think personally, I think it should be managed in psychiatry, and then the baby. Either way, if she's got severe, say severe depression, I don't think you'd want to give the baby to that patient at that point. So the baby can be kept, I think, in the well babies or in nursery, and then
You take the baby away, she starts screaming and crying and so on. You have this patient, if you try to separate the baby, the
I'm saying maybe
much worse.
acutely, I think she can be managed in a psychiatric ward, largely because psychiatric wards are built different from postnatal wards. They have all the things to actually protect the patients from harming themselves or even harming others. So when she's still acutely unwell, I'd advise that she actually goes to a psychiatric unit, and then once she's been stabilized on some antidepressants or mood stabilizers and stuff like that, then at that point, then we can maybe bring the baby to actually come and visit the mom and stuff like that. Because at the very same time, if she's still acutely unwell, I don't even think that she's, especially say she's got severe depression with psychotic symptoms. Now the judgment is completely impacted, the insight is completely impacted. So if you were to give the baby to her, I think you're actually putting that baby at risk from being harmed by the mom and herself without even knowing that she's actually harming a baby. So I think acutely, maybe manage it in the psychiatric ward, and then once the baby is, the mom is a bit more stable, then you can actually bring the baby, and then will be just a discussion between the psychiatrist and the obstetrician as to whether now they feel this mom is safe. It's safe for the baby to actually come across.
I agree with most of what he's saying. I think starting at the bottom, if the mother is severely depressed and she's crying and she's manic or whatever it is, the safest place for that baby is to be not with the mom because of problems of infanticide and suicide and things like that. So for the benefit of the baby. With regards to where the patient has to be managed, that has to be a decision made by both teams. And I think the comorbidities of the patient itself, besides the psychiatric illness, whether she's pre-eclamptic or had an abruptio or whatever it is. So we need to then make a decision jointly as to where the patient actually should be managed, but it has to be closely monitored and co-managed by both of them. Most of the time, as I mentioned, we generally involved in the acute rapid management of the patient, and the continued management thereafter is by psychiatry. But we have to make sure that any obstetric complications are also well taken care of. So it's not an easy question to answer because there's no obvious guideline as to where that patient has to be managed. And we have this interplay between internal medicine, psychiatry, surgery all the time. But patient advocation and doing what's right that you feel as the obstetrician for the patient and advocating will be the order of the day at that time. So I think it has to be patient-based. Professor Prana?
Yeah, thanks for well preparation, Dr. Nxumalo. I protected you from talking. I told him that sometimes some of us deal with stress by rushing over. But what I liked about your presentation is that it showed that you were conversant with your topic. You were not just reading slides, you had understanding. And I think despite the speed, he's done very well. And we could hear you. You know, when somebody talks from the slides and they don't know what they're talking about, you can tell. But you were talking and you showed understanding that you've read your slides to understand what you say. So well done for him. We had to listen very carefully so we don't miss.
It was a long talk.
No, this year that Dr. Moren is speaking about, so you said that at the first visit, which I think we have to keep repeating throughout pregnancy because people come through things throughout and women experience. But we can't see very well from there. I can see from my slide because I'm on the phone. But if you read those, for me, it's like, and the two questions that you alluded to, apart from this screening tool in South Africa, most of our patients have experienced a lot of things. So if you do the 2-question thing that you're screening, I think we're going to end up with almost everyone. I don't know, even if you ask all of us here, we are not pregnant. We fell down in the last 2 weeks. I felt disconnected. I felt like, I want to throw in the towel. So, yeah, I think we all have those if you screen. So we have to really pick up on something that is much more sensitive and much more not like just that. I don't know if you get what I'm saying. So can you just read for everyone what are those 3 lines?
So.
Yeah, you can't see yourself now. And by the way, yesterday at the MMed, we spoke about these slides that you leave the whole space like that, and you want us to, you understand? So just again, this is a teaching process. Expand your slide. Whatever you type, don't type 2 lines and then everything is empty at the bottom. If he expanded a little bit on that, we could see it from the distance and so forth. He can't read it himself.
You can open the slide.
Yeah,
Can increase the size of
as
it.
we speak. You can actually enlarge on it. No, you can.
If you
Get out of slideshow.
Get out of slides.
Yeah,
get
come
out
out
of
of
slide
slideshow.
show.
Okay.
And on the version where you can write your just increase it on that specific area.
Can I just make a comment?
Anyway, as they do that.
While he's enlarging. And thank you for a very good talk. I think it's great that we're screening. I find a bigger problem than screening is the access to care after you've screened, because if you want to refer a patient to a social worker or a psychologist, they're often getting an appointment that's in 2 to 3 months. A lot of the hospitals don't have access to psychiatry. So I think in addition to screening, we need to improve access to care once we've screened, because it can't just be a tick box of yes, we've screened, but now what is going to happen? So we've identified the problem, but we can't actually help that patient.
So if I can just respond to that, which is an appropriate comment. So I think before we had the screening tool, there was nothing. So you will see a patient in antenatal, you check the blood pressure, you will respond to the blood pressure, check the symphysis funnel height. In fact, you don't even do that most of the time, but you check the symphysis funnel height, you assess whether there's growth restriction, you do all those sort of things, then you send the patient home. You never even inquired whether she was okay mentally. Then she might commit suicide the next day, and then you didn't even know. So I think the fact of doing that simple screening tool means you might pick up on something. Then yes, there may be limited resources for further referral, but for example, it might just mean that the very midwife who's attending to the patient might spend some time having a discussion with the patient and just asking these questions and inquiring. Obviously, you've got to ask them in a kind of a sympathetic way, not just read it without emotion and say yes or no, and then the person will say no, and so, but just by asking those questions, it will open up a line of communication, and it might make the patient feel, oh, actually someone's interested in my social problems or my mental health problems, and it may allow further discussion. It might just be that the person is kept aside and counseled by the staff in the clinic. It doesn't necessarily mean you have to make an appointment with a psychiatrist. Obviously, if you answer yes to the third question, in the last 2 weeks, have you on some or most days had thoughts and plans to harm yourself? Then obviously that's more like an emergency situation. You don't send that patient home. You make arrangement for admission and referral to psych unit and so on. But the first 2 questions, if one of them is answered yes, then there can be further discussion. Maybe the person can be referred to some kind of on-site counselor, or maybe the person between the midwife and the patient, there could be a discussion, and there could be some kind of small plan made about how things could be, how she could be helped. So I think just asking the questions is an important let's say, new aspect to the way we do antenatal care, which we've been ignoring over time. But yes, it's acknowledged that there aren't always the ideal resources to refer the patient onto. Are you going to read them?
Okay, the first question is, in the last 2 weeks, have you, on some or most days, felt unable to stop worrying or thinking too much? And then the answer could be either yes, no, and then if it's yes, you give one, you score it 1 point basically for the ones that said yes, and then the ones that said no, then you want they scoring 0 basically. And in the last 2 weeks, the second question now, in the last 2 weeks, have you on some or most days felt down, depressed or hopeless? Again, yes, they get 1 point, and then no, they get nothing. And then the third question reads as, in the last 2 weeks, have you on some or most days had thoughts and plans to harm yourself or commit suicide? Then again, if the answer is yes, then you score 1. And if it's no, you're not scoring anything. And for those that score 2 or more, then you have to refer. And 3, or as well as 3, you have to refer. So basically, if it's greater than 2, you have to refer. Not sure if with 0 and 1, then, with 1, but then we just don't do anything.
It's like,
No, as you said, with 1, you have a discussion with the patient, you debrief them, you go through their social problems, etc., and you see where they need to be helped. Yeah. Any other questions or comments? Okay, thank you, everyone.
There are no questions.
Oh.
Hands raised. Then.
Let's see from the chat, doesn't look like it.
Okay.
Okay, thank you, everyone. Enjoy your weekend.
Thank you.